Uh, Welcome everyone to another virtual seminar hosted by the Center for Clinical Medical Ethics at Columbia University Vagelos College of Physicians and Surgeons in New York City. My name is Lydia Dugdale and I'm the director of the center. And it's my great joy to welcome you all virtually and especially in honor of Dr. Craig Blinderman, one of our own physicians, highly esteemed at Columbia and much loved by the students. Tonight's topic was actually suggested by our students, our medical students who are interested in ethics. Everyone is eager to learn more about palliative care and to make sense of living and dying well. And so we're delighted to have Dr. Blinderman speak. I'm going to turn it over to Hart Fogel, who is our ethics representative from the medical student class, and he will give a formal introduction for Dr. Blinderman. Thanks, Hart.
Hi, everyone. It's great to see so many of you here. So I have the privilege, as Dr. Dugdale said, of introducing our speaker tonight. Dr. Craig D. Blinderman is the director of the Adult Palliative Medicine Service at Columbia University Irving Medical Center, New York Presbyterian Hospital since 2010, and an associate professor of medicine in the Department of Medicine, Columbia University Vagelos College of Physicians and Surgeons. He was previously an attending physician on the palliative care service at the Massachusetts General Hospital and co-directed the MGH Cancer Pain Clinic from 2007 to 2010. Dr. Blinderman has published numerous original articles, reviews, and chapters in the following areas: comfort care for the dying patient, early palliative care in lung cancer patients, palliative care response to COVID-19, the role of palliative care in left ventricular assist device patients, medical ethics, and a range of other topics in palliative and end-of-life care. He's currently the section editor for case discussions in the Journal of Palliative Medicine and a member of the editorial board. Dr. Blinderman also serves on the advisory board and teaches at the New York Zen Center for Contemplative Care in New York City. He also has a strong interest in teaching and developing programs to improve medical trainees' skills in communication and care for the dying. Without further ado, I'll turn it over to our speaker, Dr. Blinderman.
Oh, thank you so much, Hart. And thank you, Lydia, for the invitation. It's really a pleasure to be here. I'm really honored to be part of this and that hopefully it will benefit our students and other attendees who are listening. So without further ado, let's go ahead and get started. So I'm going to share my screen and with hopefully no major Zoom problems. We should all be able to see the first slide. Okay, so I titled this talk, Ethical Issues in Palliative Care, Ethical Dilemmas in Palliative Care, the Near and the Far. I shared with Lydia where there's a Heidegger quote that kind of came to me that sort of inspired that talk. It has nothing to do whatsoever with this talk, but I'll just share the quote. It was on his essay, Who is Nietzsche's Zarathustra? And he writes, "Longing is the agony of the nearness of the distant." I'll just leave that with everybody to go down some rabbit holes this evening on the interwebs and try to understand what that's all about. So my only conflict of interest, and you'll see where this will come up, is a little surprise here in the talk. So I've been invited to be a member of the Scientific Advisory Board for Novamind, which does help in terms of thinking about access to psychedelic assisted therapies around the world. And it's sort of a venture startup that's looking to expand our knowledge and understanding of both clinical and research of these kinds of therapies. And you'll see how that may or may not have anything to do with what we're talking about today. So the near. So we're going to start with a case, and this is very near. I was just talking with a colleague. I mixed up the details a little bit of this case, but I had a conversation with a colleague tonight. He may be on this webinar. And he was sharing with me a struggle that he was having with one of his ALS patients. And so I kind of turned the case into an ALS case, and I thought that just made sense. And it could be a number of individuals who have serious or life-threatening illness and are facing the end of their lives. So this is an 82-year-old male, professor of medicine at a top US medical school. He's been struggling with progressive ALS for the past 5 years, bulbar presentation. He's now fully dependent in his ADLs, wheelchair-bound, struggling with eating due to dysphagia, and with concern for future aspiration. He has profound dysarthria as well. He's not interested in any life-sustaining treatments to prolong his life, no feeding tubes, no IVF, no IV fluids, I should say. I don't want a different connotation here. No tracheostomy. He's been DNR, DNI since his diagnosis. He communicates with great difficulty because of his dysarthria. He states that he can find no meaning in his life at this time. He worries about being more of a burden, and he expresses no hope for the future, though he does acknowledge some pleasure at times, for example, taking a bath and listening to music. He expressed that he has accomplished all that he's hoped for in life, and now would like to hasten his death before any further loss of functioning, which he worries is going to strip him of his dignity, control, and inevitably cause more suffering. He has chronic pain, which is not optimally controlled, and has some constipation. Otherwise, he denies any significant symptoms, has no psychiatric history, and was not felt to be depressed or have any other psychiatric diagnosis. He's contemplating physician aid in dying in New Jersey, where he lives, or stopping eating and drinking, and wants your assistance. So I'm just going to leave this as an open question. How do you think about this ethically and clinically? And if I could see your faces and interact with you, I might call on someone who has their hand up. But this is, let's just leave this as a kind of an introduction into thinking about physician aid in dying and what we're going to get into talking about options of last resort. This is a very tricky area in palliative care, and I think really takes us up to the edge of where we feel comfortable in what is under our purview in terms of medicine, and how do we approach suffering at the end of life. So I think just some general moral questions we should be asking whenever we're faced with questions anywhere along these lines. Is it ever permissible or justifiable to kill another human being? And if so, under what circumstances? Generally, when I ask this question to students, we get a variety of answers. Some of the most, let's say, classic examples you might hear in moral philosophy classes might be killing in self-defense, right? Which was first articulated and argued by Thomas Aquinas, and so that's something that we can imagine perhaps being permissible, justifiable. Another example that people often give is a mortally wounded soldier on the battlefield who is not going to ever get to triage, and you have a vial of morphine. Is it okay to use that entire vial and take the soldier's life? And that's often thought to be another justifiable or circumstance where this would be considered permissible. Is there something inherent in being a healthcare professional that prohibits her from helping her patients die? What is that discomfort that comes up when we hear about this case, and how are we going to feel as we move forward with either actualizing this patient's desire or seeking some other solution? And should we legalize physician-assisted suicide, or physician aid in dying, as it's called, for patients at the end of life? So there's a question for society, and a number of states have already weighed in on that question, New Jersey being one of them. So just to take us through a quick historical ride, in this country, there had been a movement of what's called the Right to Die movement, and that had culminated with a couple of Supreme Court cases that were just decided in 1997. Excuse me, they're both decided, or their decisions were released on the same day in June of 1997. The first is a Washington v. Glucksberg case, which argued from the 14th Amendment that there's a due process clause which would protect a right to commit suicide, which itself includes a right to assistance. The Supreme Court ruled that the state's interest in preserving life, protecting vulnerable patients, and maintaining the integrity of the medical profession are sufficient reasons for justifying a prohibition against physician aid in dying, or physician-assisted suicide. I'll just call it PAS for now. And they felt that the right to commit suicide is not supported under the due clause. In her opinion, however, Justice O'Connor did argue about supporting the use of medications for pain relief, even if those doses could hasten death, so long as the physician's intent was to relieve pain and suffering and not end the patient's life. And she kind of was hearkening here a little bit implicitly of Thomas Aquinas's rule of double effect, I mentioned earlier. And this kind of moral argument really comes out of his discussion of self-defense, and whether it's okay to defend yourself, even if it results in this unintended consequence of killing another individual. And so this is a rule that's often applied to moral dilemmas in which it's impossible for a person to avoid all harmful actions. It's going to be some kind of harmful action. So how do you think that through? One, the nature of the act must be good, or at least morally neutral. The harmful effect must be foreseen but not intended, and the harmful effect must not be a way of producing the good effect, and the good effect must outweigh the harmful effect proportionally. So in other words, the Justice O'Connor was essentially relying on this kind of understanding of this moral argument that indeed, if doses were necessary given the proportionality of suffering, given that the fact that there is it's considered a morally neutral act, and the harmful effect, while it could be foreseen, that's not the intended effect. And you're not bringing about the end of the patient's suffering by means of hastening their death. It's simply by using medications with the unintended consequence, perhaps. So that's where that ties into the court ruling. And a second case in 1997 also tried to argue that there's a legal case for the right to die under the United States Constitution. This is Vagelos v. Quill. And those of us in the palliative care world know Timothy Quill, and he was in fact the defendant in this case. And he was taken to essentially went up the legal court system in New York State, where Vagelos was the attorney general at the time, after he had disclosed in an anonymous, ultimately turned out to disclose that he was the writer of a piece that revealed him helping a patient take her life. And so they were arguing under the Equal Protection Clause of the 14th Amendment, that is to say that New York accords different treatment to those who are competent, terminally ill persons who wish to hasten their deaths, for example, by self-administering drugs, than it does those who wish to remove life support. They were saying that, if I don't have life support to remove, how else could I end my life? And so that was their argument, that it sort of should be protected on this Equal Protection Clause, and that New York got it wrong in making a distinction between the two. And the court ruled, actually, there is a rational, logical, and well-established distinction between refusal of life support and treatment for PAS. And they felt that this hinges on causation, that when a patient refuses life support, the patient ultimately dies from the underlying fatal disease, versus when a patient ingests a lethal medication, the patient dies from that medication, and the court left it up to each state to decide its policy. So this I'm going to summarize, because since we're on this topic, I think it's important. That's the legal arguments, and that's sort of where we were left as of 1997. And a number of states have since passed legislation to have physician aid in dying, or death with dignity, or other names for this process, this practice. But I think it's also important to focus on some of the ethical arguments that have come out in favor of it. And some of this was taken from a very interesting debate, with Timothy Quill and Daniel Sulmacy back a number of years ago at Barnard College, which I attended, and felt that there were some really rich discussions there. And I thought I added some of this discussions to the two arguments. One was for and one was against. So it's kind of an interesting dialogue. And so this is, in a sense, not a summary of their discussion, but at least they were highlighting the main arguments, which I thought was worth sharing. So autonomy for that in argument in favor of PAS. Patients should have the right to choose the timing and manner of their own deaths, that there should be some degree of mercy, or the way we think about caring for patients at the end of life, that doctors have an obligation to prevent unnecessary suffering, and that doctors should help provide a compassionate end rather than letting someone suffer unnecessarily. And lastly, non-abandonment. Imagine the patient who said something like, I thought you said you would help me at the end, so I wouldn't suffer. So that worry about abandoning patients at the very end. So those are the strong arguments in favor of. There are a number of arguments that have been presented against physician aid in dying. I'll just summarize a few of them. The difference between killing and being allowed to die regarding intentionality and causality. The response to mercy argument, one could say, well, physician aid in dying or physician-assisted suicide is not really necessary. We can actually use palliative sedation, voluntary stopping of eating and drinking, withholding life support, et cetera, to provide compassionate care at the end of life and not prolong someone's misery in most cases. The concern that desire for legalizing physician aid in dying may be linked to the failure of our healthcare system to provide compassionate, patient-centered end-of-life and specialist-level palliative care, that it's a failure, and that our healthcare system's inadequacies and coverage of pain and palliative care treatments may lead individuals to be more likely to want to choose physician aid in dying versus continued treatments or care that have failed through the patient or the family distress. So this is a kind of a cynical argument in the sense that, if we just deny patients coverage of things that might be of benefit to them, then you're going to be legalizing some other option for them when they're not actually getting the standard of care to begin with, and so not really giving them much of a choice. And proponents of palliative care might say, well, if you actually enhanced funding and access to palliative care, then these kinds of questions would be less common, or not common to begin with, but be even less of an issue. And surveys show that when patients seek PAS, they're doing so for feelings of dependence, being a burden, feeling tired of their life. And quite frankly, these are not medical reasons per se. So should the treatment be medical as opposed to social, psychological, or spiritual, if indeed that's the cause of it? The duty to respect patient autonomy is not absolute. Just because a patient wants something doesn't mean it needs to be provided. For example, there's no obligation to provide a treatment that's not medically indicated. And then another question could be raised, is this really about control and autonomy, or does this really reflect a desire for some kind of social or psychological approbation and giving them permission from doctors to end their lives, that they're so miserable and suffering so much that if the doctor says it's okay, then somehow that's okay. This gets into a question, I think, of intrinsic value versus attributable value in human life. So in other words, someone who could argue that allowing the terminally ill patient to end his life is saying on some level that your life no longer has value. And so that's looking at life as having attributable value versus intrinsic value, whether it be stemming from dignity or some other place. Equal access will inevitably lead to euthanasia. For example, how will the ALS patient in this example be able to take pills on her own? Right? And that's part of the legal right, at least at this point, is that it's an act that the patient does him or herself. And suicide is not a self-regarding act. I love this quote. This is from Ned Kassem, who was a former chief of psychiatry at MGH. And he said, "In whose closet will you leave your skeleton?" Right? That there are the implication of that is that our taking of our own lives somehow is not just we just disappear from the world, but rather there is something else for everyone else to have to deal with. The Hippocratic Oath arguably sets some floor for what the medical profession is and isn't. And without these rules, societal trust in physician enterprise will likely erode. We're not supposed to take bribes. We're not supposed to have sexual relations with our patients, and we're not supposed to offer them a lethal overdose. I mean, these are some of the basic principles that were set out in the ancient world. But what about refractory suffering without a terminal illness? Someone could argue, shouldn't we expand physician aid in dying to those who are not terminally ill? And why is prognosis morally relevant? And should it be? So there's some people would argue that there's some inconsistencies within the argument for physician aid in dying. Why not extend it? And what's so special about the last 6 months of life? And physician aid in dying is an act of violence not consistent with what it is to be a healer or physician. So some people would argue that it's outside of our bounds in the profession. So I just presented all of that by way of background, because I think it's so easy to get caught up in the questions, these ethical questions that are coming up, that some of which we can argue here, all evening, and it can be a lot of fun, and we can learn about where they come from and what assumptions are being made. But I think on another level, might we be focusing on the wrong thing when we're having this ongoing debate about how to address questions like the patient at the very beginning of this presentation, who's requesting to hasten his death? And might we reframe it or turn the question and think about, how do we address and mitigate suffering when someone requests to hasten their death? And what is the cause of their suffering? And how much of that can we explore, and how much of that is something that could be changed? And I leave that as a very open question, because this is really, I think, what gets to the heart of what makes this so uncomfortable and so difficult is, how do we define this? How do we engage with suffering? And what do we think is too much? And where do we draw those lines with individual patients, with ourselves, with our own practice? And so you can imagine how this very much takes on a subjectivity that's very difficult to standardize. And so that's something that I just want to put out there. I think it's also important to have this in the context of, how do we think about this altogether in the context of these other options of last resort. So we talked about physician aid in dying. We won't talk about euthanasia. That's not an option. That's not something that's legal in this country. But the other ones are options. And how do we think about them? And how do we advocate or guide patients accordingly? Or do we even need to get to these options of last resort? And that's what we'll be talking in a moment or two about other possibilities. So we know about aggressive comfort measures. This is providing pain and symptom management, even to the point potentially of some degree of sedation. And so this is one of the ways in which we can deal with significant suffering, but not with psychoexistential suffering, not with the kind of suffering that we were hearing about from our initial patient, about feeling that that's a burden to be alive, not finding any hope for the future, and finding there's no meaning in continued existence. Could he refuse life-sustaining treatment? Well, yes, he's already done that. He's already said, I don't want a feeding tube. I don't want any tracheostomy. I don't want any IV fluids, and I'm not interested in prolonging in any possible way with any life-sustaining treatments. And what about voluntary stopping of eating and drinking? Well, that's another option that's often available and talked about in the literature as being legally permissible. The alternative of forcing someone and force feeding them with a surgically placed gastrostomy tube is not considered to be an ethical option, inhumane by most standards. And so the alternative then of if someone is refusing to eat when they're able to, what can be done about that other than trying to work with them on other nutritional options, but if they're really consistent on doing that. And there have been a couple of cases that went in New York State, at least, that have shown that those patients do have a right to refuse, and it extends from the right of refusal that's based in autonomy and our bodily integrity, and so not wanting to have a feeding tube inserted when you've stopped eating, different than someone with a psychiatric diagnosis, let's say of anorexia nervosa. But this has also been shown in a couple of other cases as well. The Bouvier case is another classic example, which and then led to some other questions about feeding tubes and so on, and depression and making decisions in the context of a depression when you're refusing the actual feeding itself. And then we get into palliative sedation. And I think if we can look at that in a little bit more detail, this may be a sort of an entry point, at least into the ethics of thinking about these options of last resort in more general terms. So let's just focus in a little bit on palliative sedation. This is one article that I really like that kind of tried to highlight, if you were to justify or determine whether this practice is ethically valid, you were like going through past experiences in hospices or in inpatient units, and you've seen this practice, what would make it ethically valid? And so they came up with these a priori criteria, and then they did a chart review to then see if they would meet these criteria. And so the three things that came up was, one was intentionality, seeing the degree to which someone titrates medications and dosing could suggest their intentionality if they're trying to hasten their death with a large overdose versus titrating up based on desire of sedation or certain symptom management needs. Continuation or initiation of artificial nutrition and hydration. So that conversation is supposed to be happening at the same time that you're talking about this. That is to say, it would be a little intellectually dishonest if you're introducing the option of sedation and don't talk about what are the options for feeding if the patient is in fact still eating on their own, and they would otherwise continue eating on their own had it not be for the sedation. So that conversation has to happen. Often patients will just say that they're not interested in eating, they don't want a feeding tube, and that's okay with them. But it's still something that needs to be thought about or documented in some way. Proportionality, this is what we talked about earlier, this notion of intolerability of suffering, the refractory nature of suffering. And sort of where they are in terms of have they received standard palliative treatments and what makes their suffering refractory. And we're going to hone in on this a little bit in a moment or two. And then autonomy, that there must be a clear informed consent given, and this is not something that someone should be coerced or not weigh in on based on their underlying values and goals as expressed by a surrogate, for example. So if we lean in a little bit to this idea of the refractory nature of suffering, so at what point can we say when suffering has become refractory? It's seemingly easier to do when you're dealing with physical pain and other symptoms, because that physical suffering can more readily be appreciated as intractable rather than non-physical suffering, which is we have a harder gauge in how much is someone internally suffering. And I think some people have better ways of understanding that than others. But I think the physical realm of suffering, one can see that a little bit more in a more obvious way. And there are standard treatments, right, for most symptoms. So we're not talking about something like psychoexistential suffering, where if it's not really grounded in let's say a treatable psychiatric condition that we might find as being something that's reversible or treatable, how do we think about existential suffering? How do we think about lack of meaning in the future? How do we think about feelings of hopelessness in the future, but not necessarily having a sense of anhedonia in the present? So this idea of this future is not having any meaning. How do we treat that if it's not truly a depression or if there's some overlap there. So there's really no standard treatments for existential suffering, or might there be? Or might there be some experimental ways of thinking about this? And I would argue, and we'll talk about this in a moment. So this is with respect to palliative sedation. So it's just also to highlight this idea of how existential suffering is kind of a different animal, and it's a bit harder to know. And so this is from our Academy's statement on palliative sedation. I think this is right after, or right where I was involved in their ethics committee for a while. So I think it was right after I had served my time, but we did debate and talk about this issue about palliative sedation when coming up with a position statement. And one of the things that was talked about and ultimately put into this statement is the idea that existential distress may in fact cause significant suffering of great magnitude. There's really no consensus, as we said, about defining it, assessing it, gauging it, or measuring the efficacy of treatments, at least at the time when this was written. And so the thinking is that these patients should be thoroughly assessed and treated through vigorous multidisciplinary efforts, which may include professionals who are not usual members of the team, the palliative care team, that is psychological, family therapy, spiritual, et cetera. And if palliative sedation is thought to be used in these truly refractory cases, its use should be for physical symptoms. It should not shorten survival. So this is one of the ways in which it's being thought of. And so just to go back to this idea, so when we're thinking about no standard treatments, it's true, we don't have any standardized treatments, but there is some treatments that show promise. And so might there be a way of thinking about if we had a treatment, an experimental therapy that might be able to help alleviate or diminish the kinds of existential concerns that are arising, and leaving the patient in a different state of how they see their lives and how they see their connection to the world, might that be something that patients ought to be able to receive? And so in fact, there is this case that right now, actually, there's some legal case that's happening right now in the state of Washington. Actually, one of my colleagues is working with a law firm to represent one of his patients who is hopeful to try experimental psychedelic assisted therapies. Now, why that of all things? Well, some of us who are aware of the literature have found that there is actually some decent evidence that's been coming out in the last several years. There's actually a JAMA article in this past year on psilocybin assisted therapy in the setting of depression, major depressive disorder. And we also saw it in 2016, two articles came out in the same issue of Journal of Psychopharmacology that dealt with using psilocybin in both cases and finding a marked reduction. They were looking at anxiety and depression as their primary outcome, but in both studies, and I'm just going to show you the results of the Ross study from the group at NYU, in both studies, they did see marked reductions in what they might call existential domains, improvement in the sense of hopelessness, demoralization, and the feeling of having more meaning and more peace in their life, and a whole host of other things were found. But these kind of struck me as being something's going on here. That they're tapping into something beyond just the emotive aspect of, let's say, something like depression and anxiety, and they're tapping into something here that we might call more existential or spiritual in terms of their suffering. And another finding that they had, which I think is really remarkable, or at least may offer us a new way of thinking, not a new way, because Carl Jung talked about this years ago, that the numinous is actually what he's really all about. And that if we leaned into that and were able to allow for these mystical experiences to actually take shape, we'd actually be able to be relieved from the curse of pathology, as he said. And so what they found is they used this mystical state, or mystical exam questionnaire, the MEQ. And so their mystical experience questionnaire, And what they found was a correlation with higher scores on this mystical questionnaire. So in individuals, participants talking about how this was a transformative experience for them and describing in all sorts of terms that was consistent with this tool, it actually showed a higher degree of reduction of anxiety and depression. So there was this really interesting association that may be able to think about triggers or a mechanism perhaps for another way of thinking about reducing psychiatric symptoms. And so it's not mechanistic in the sense of understanding it from a biochemical standpoint, although we understand to some extent that largely these are serotonin mediated events with 5-HT2A receptors that are largely involved in psilocybin regarding brain activity. That being said, this is really more of a phenomenological understanding of what's happening within the individual and the impact that that's having on their mood, or what we're calling their mood. So this is, we now have a safe use of psychedelic assisted therapies forum at the AHPM, which is our national academy, our American Academy for Hospice and Palliative Medicine. And like I said, there is a case right now that's being worked on in at the state of Washington from a law firm that is looking to represent a patient there in having this right to try, almost like a compassionate use when we think about using experimental therapies for patients at the end of life, with this level of evidence that there is some significant improvement in some of those existential domains. They're making the argument that before we consider these options of last resort, like having to stop eating and drinking, might it be possible to transform the experience of the patient at the very end of life to have a new way of seeing themselves in the world and not being exposed to a degree of existential suffering that is constantly at bay? We'll see. This is what's happening, and so I wanted to bring us right to the edge and going to this very close kind of case of right here in our Columbia community, and then thinking about the broader implications that this might have as we start thinking through, as we get more clinical experience and research is conducted. I think we're going to see more and more of these kinds of cases going for a right to try types of approaches. Mdma is another one that's coming out, and there's a lot of studies and some very close to FDA approval for PTSD. So I think we're going to start seeing more and more of this. And what I wonder is, how might that shake up this whole model that we have of options at the end of life and the last resort options that we think about when patients are truly suffering? Might we think about other options before we get there? So that was our first case. That was the near. And I think we're right at the halfway point. So I'm going to just launch into the second part of this, the far. And so the second part of this talk, I think, actually takes us into our present moment as we're dealing with a global pandemic. So let me just read the scenario here. This is, let's say, something that we may encounter. You're part of a team consulting for the Ministry of Health of a resource-poor country, part of a Columbia-sponsored intervention through Columbia World Project regarding COVID-19 vaccination distribution and other measures to ease the burden on the healthcare system with the current pandemic. The Minister of Health you're working with proposes to reduce budgetary spending on important morphine and use the money saved on importing morphine and use the money saved to purchase additional vaccines, PPE, and testing sites in rural parts of the country. You think this is a reasonable proposal, but wondered about the ethics of prioritizing public health measures in the setting of a global pandemic over the relief of pain and suffering, which you know is also priority. So how do we think about this? This was taken from over a decade ago from the New York Times, describing the disparity in world consumption of opioids and access to pain medications in the most poorest of countries. This is both in September 10th and September 11th of 2007. And they just did a really incredible profile of understanding this problem. And this is what it would look like if you were to take the relative size of countries and put them on this map, with the variable being, the dependent variable being the oral morphine equivalent consumption per country size. You can see the very bloated countries of the US, Canada, and Western Europe, and Australia, and everything else, even though in landmass, are actually shrunk in respect to that. So, in other words, of the world's total population, the 17% in the high-income countries consume about 91% of the world's opiates. Now, granted, that is a proxy measurement for the ability to recognize and treat suffering. But I think we've seen in recent years and in a recent Lancet paper that I'll share with you, how much that problem still exists. So the problem is really simple, in that, or at least simple to describe. It's not simple to solve. Many countries have not considered palliative care or pain relief a priority in public health, and this was even coming from the WHO's statement from 2007. With limited resources, disease-oriented therapies and prevention measures often take priority. So how do you consider the role of pain relief and palliative care when it competes for other public health resources in a global pandemic? How do you make sense of this? How do you think about what would be a just health policy or just public health policy in this arena? And this was an unfortunate misconception that Paul Farmer, I think, ultimately backed away from, but this kind of led me to think about this issue. He wrote in a Foreign Affairs piece in 2007 that palliative care, in quotes, "a code for helping people die with less pain, should not be used for disease that strikes mostly young adults and children unless that disease is untreatable." So I think he was really highlighting this kind of false dichotomy that palliative care is really something that we're only offering patients who are dying at the very end of life. And we'll come back to that false dichotomy and how much that has maybe plagued the extent to which palliative care has been improved upon over the last decade or so, and the work that still needs to happen there. So there's clearly a need for palliative care in global health. We know there's prolonged advanced illness and dying process in the majority of deaths, growing incidence and prevalence of cancer, the HIV/AIDS epidemic that is still very much with us in some parts of the world, and an aging population. And we'll talk about COVID in a moment. This is the paper I was referring to that came out in the Lancet. It was in 2018. One of my colleagues and friends, Eric Krakauer, was very much involved on this, and Paul Farmer, as you can see, who's from Partners in Health, and some of the work that he's done overseas in bringing light to places that are not getting adequate medical care. Has done incredible work in Haiti and elsewhere, and so this came out. It's a 60-page document. Actually, the entire issue is devoted to this. So there are multiple commentators and other submissions around this theme, and they found some astounding results that in this 1-hour lecture, we're not going to dive into them. But needless to say, they found an extensive degree of suffering, and we're even able to describe what serious health suffering is and quantify it around the world and show the disparities and how much it attributes that to low and middle income countries. So that was really a major breakthrough in terms of understanding the public health concern about pain management and palliative care. So it's clearly an issue. But I think when we go back to that case, when we think about, well, how do we think about that, and in what ways should we be reconsidering things like pain management or morphine when you're also struggling with other priorities, and what kind of moral arguments can be given, and how do we frame that in the context of trying to provide just healthcare around the world? So it does require us to think a little bit about justice, to think a little bit about how do we justify healthcare in our society and around the world, and what is that based on? And so that's what we're going to spend the next half of this hour talking about, or next 15 minutes or so talking about. And so obviously the last item that I put in here to update this slide is, of course, with the current pandemic, and thinking about the role of palliative care in this context. So one way of asking the question is, are we morally obligated to provide palliative care even when resources are limited? And if so, what is the justification? Are there other moral considerations to think about for the provision of palliative care? Again, especially when we're considering some of the lower and middle income countries. And how do we assign priority to palliative care when resources are limited and healthcare needs are great? And what are the benefits to society if we adopt maybe a utilitarian approach in that? So these are the questions that I want to try to answer. My argument and my response to Paul Farmer at that time was that actually palliative care is really part of comprehensive medical care. It's not siloed off as something that's only given to patients at the very end of life who are dying. So it would be required in a just healthcare system. We'll talk about why I think that's the case. The duty to relieve suffering is another moral consideration and should be part of the discourse in any fair and transparent deliberative process of weighing public health policy proposals. So no matter where you go in the argument, it's not going to be an either or scenario. It's going to be really about deliberation about these other priorities that should also be considered and not waved aside. And then, of course, there are other moral considerations like the utilitarian value of palliative care that may also be used to provide justification when there are scarce resources. And we'll talk a little bit about our own experience here at the Columbia Medical Center. So we often hear this, that healthcare is a human right. It's actually one of the slogans of our public health school, the Mailman School. So how do we get to that point? How do we establish that healthcare is a human right, and under what sort of moral justification can we make that claim? And so I'm gonna argue that I think a lot of this actually comes from John Rawls and his theory of justice. And just to give a background, for those of you who are not familiar with Rawls's work, 20th century philosopher who really probably made the strongest claims to a coherent theory of justice that's been widely accepted and actually utilized in many public policy framings. So I think it's a good place to start. I'm not going to go into all the other theories of justice that have also been out there and criticisms and so on, but let's just start with Rawls and sort of work our way through to getting to public health. So his attempts to solve the problem of distributive justice, and his ultimately is resulting in this contractual theory called justice as fairness, which is widely held to be the most important theory of justice, as I said, with practical implications. I love this. So why can't I stay up late? You guys can. It's not fair. The world isn't fair, Calvin. I know, but why isn't it ever unfair in my favor? Well, that's precisely what Rawls was worried about. In his original position, he worried that he basically was a thought experiment in which rational agents are to sort of think through what are the principles of justice. If you were to frame society sort of de novo, out of nowhere, frame this new society, what are the principles of justice that you would need in order to make sure the basic structure of society is upheld? And he called this the veil of ignorance. So you wouldn't know what your position is in that society. You might be a laborer, you might be a king, you might be, et cetera. There was no way of knowing that. So that's the veil of ignorance. So to Calvin's complaint, he wanted to make sure that you weren't going to be unfairly advantaged in this if you happened to be born into a wealthy family and didn't have to deal with certain inequities versus born into another state. So he wanted to have this position, this original position. And what he was asking in this thought experiment, these rational agents, was how do you distribute the primary social goods, which he talked about as being basic rights and liberties and economic and social advantages. So how do you share this? What's the best way to do this in a just society? And he came up with this idea of justice as fairness, and it consists essentially of two principles: that all have the greatest degree of liberty, compatible with like liberty for all, and that social and economic inequalities be attached to positions open to all under fair equality of opportunity and to the greatest benefit of the least well-off members of society. So whatever advantages exist, they need to flow to the least well-off members. So that's essentially the starting point for thinking about healthcare potentially being grounded in this theory of justice. And then along comes Norm Daniels, a student of John Rawls, and actually someone who I had worked with a bit on a paper that I had written in response to Daniels's own claims about healthcare and justice, and wanted to both extend his argument and argue that there were some limitations in how he thought about things. So the major argument really relied upon to justify the spending of public health dollars really comes from Norm Daniels. And essentially he's arguing that healthcare has special moral importance. And why is that? Since healthcare promotes health, what he would describe as normal functioning, and health contributes to protecting opportunity, then healthcare protects opportunity. And since a just society is interested in protecting opportunity under Rawls's justice as fairness, then justice gives special importance to healthcare. That's essentially his argument. But if we look at this a little bit more carefully, and you think about palliative care, it seems to me, at least, that we'd have to go beyond justice in some sense, to think about palliative care. So unfortunately, his argument does not work as patients progress towards death, when opportunities and normal function become limited and approach zero over time. So we may have to think about other things like dignity, saying goodbye, being free of pain, maybe some age relative opportunity range, and have this maybe more expansive view of normal functioning and or opportunities to include if we wanted to use Daniels. But I worry though that would take us so far. It seems to me that we also have to think about the duty to relieve pain and suffering. Philosophers have made this point in over the centuries. These are just a couple of examples from Thomas Nagel and Jamie Mayerfield in terms of thinking about the objective reality of pain and our obligation to relieve it when we see it. So suffering is bad not only for the individual whom it afflicts, but bad from an impersonal point of view. Its occurrence makes the world a worse off place, and that we are then obligated, or we have a prima facie duty to prevent it. It's also a utilitarian argument that can be made for prioritizing palliative care and public health. We know this higher quality of care that's delivered with specialist level palliative care, and there are cost savings, including some of the work that we've even shown here, and I'll end with that. This is how I was sort of thinking this through a little bit when you're thinking about placing palliative care with other disease-modifying therapies and other public health priorities. You can see if the goal is to maintain normal functioning, then of course things that are going to lengthen life, vaccinations, treatments, all those kinds of things are going to be guaranteed under that justification. When we think about the moral justification for palliative care, we might have to appeal to these other ethical principles that are beyond justice, or maybe include in a more expansive view of what do we mean by normal functioning or opportunities, and might being free of pain, relief of disabling symptoms, and others be some kind of a new addition to that grouping. But I think that's not a fair enough way of thinking about this. I think actually you can justify most of palliative care under thinking about comprehensive medical care, which would fall under the same category and be required from a principle of justice. And then it's only at the end of life, in those last days, weeks, or months, where you can make a separate argument outside of the justice argument that society has a strong moral responsibility to relieve suffering, and that these other moral considerations and societal values may take a higher role than simply going towards normal functioning. And this last, I'll just end with some work that we did here in the emergency department during those peak weeks and months of the COVID-19 pandemic in New York City, and had shown a significant decrease in what would ultimately have been resources, scarce resources in the ICU, life-sustaining treatments. We saw after a palliative care encounter, a number of individuals who had decided to, or with their families' surrogacy, had decided to not choose a plan of care that includes going to the ICU or with life-sustaining treatments, and instead were provided comfort care. And so that made a big difference in terms of resource utilization. So if you're thinking about some degree of a utilitarian framework, you can imagine that some resource-poor countries might actually make an argument that actually increasing the degree to which palliative care is integrated into their healthcare system might actually have some additional benefits aside from those of relieving suffering, but actually may improve the value equation in healthcare, namely decreasing costs and increasing quality. So well, I'll just end here by saying the principle of justice is not the only moral consideration involved in the provision of healthcare. The duty to relieve suffering is at least as fundamental as protecting opportunity, especially as patients approach the end of their lives. There are other compelling moral considerations to include palliative care as a public health priority in resource-poor countries, including a utilitarian argument for benefits of palliative care to the healthcare system. And then lastly, distinct moral justifications offered for integrating palliative care, or what I call comprehensive medical care, are important since they may be given different weight in different societies under certain conditions. So ultimately, what I wanted to give that Columbia student who's working with the Minister of Health on this CWP project is the moral language to go into this conversation and to think about how do we prioritize these different things, and how do we think about making those arguments. It's not an all or none phenomenon, but it's really one of deliberation and weighing priorities. And I'll end there. I know we have about 10 or so minutes left, so I'll stop there and see if we have any time for questions. And I'm sorry if I went a little bit over, Hart. I saw your hand went up there, but I just knew I had a few more slides to go through. So So thank you, and sorry for going a little bit over the time
Right.
allotted.
That was amazing. That was 3 talks in one, and we did it on time. So incredible. I'm going to, several people have asked if the slides will be available. Yes, they will be. We will email you the link when it's posted. We dropped the email address for the center in the box if you would like to sign up for our listserv to hear about future events. And final thing, if you have questions, please put them in the Q&A. Dr. Blinderman, I'm going to take moderator's privilege really quickly and ask you questions.
Please,
so psilocybin.
Yes. Yeah.
Psilocybin is opening the door to the existential, the spiritual, the mystical. That was all language that you used. And
Correct.
I think the other place that opens that door is religion, right?
Correct.
And
yeah.
so, our colleagues at Harvard School of Public Health just published a study a year ago in JAMA that showed that if you go to church or religious services once a week, you have a 68% less likelihood of dying from deaths of despair for women and 33% reduction for men. So I'm wondering, would you, in your work, also in your new consultancy role, would you see any room for randomizing people either to religious service attendance or psilocybin use?
Yeah. I think I actually deleted a slide that I put together for a talk that I actually gave at UPenn the other day on this very subject, on the potential role for psilocybin assisted therapy and palliative care in the future. And so one way of thinking about it is, if indeed there's this mystical experience that seems to be this numinous experience that seems to be potentially one of the ways in which we're changing the brain and changing our subjectivity towards our own suffering and how we relate to others, there are probably other ways of getting there, right? And I think so religious experiences, we just think about William James's, the varieties of religious experience. He was very deeply interested that what are the psychological states that people of faith of all different types of religious experiences have, and he found some commonalities there, and tried to describe these kind of mystical states that people were experiencing. So you could call them like ineffable, numinous, having kind of a noetic quality, transient. These very specific aspects that were common to multiple religious practitioners, from anything from Tibetan Buddhist practice to Christian ascetic mystics. So I think you can see a range of that kind of practice, whether it be from an Eastern tradition or a Judeo-Christian tradition, and that's just one element. There may be other ways to get to that experience too. People talk about the sublime, having an encounter in the wilderness where your life is maybe it's not so clear that you're going to survive. And then there's this kind of sublime experience that happens. What is that? And how does that change? And we talk to people who've survived events like that and how they have this transformative way of seeing their place in the world, even if their time is short or even if they're disabled and so on. And so I think there are a lot of other ways of getting there. Certainly the religious experience, especially if we think about William James's work and Carl Jung, and I think about how do we tap into the numinous. And I think psilocybin is only one of many avenues that I think is worth further exploration, for sure.
And there's a question specifically on how we could go about changing perspectives on potentially beneficial substances such as psilocybin that are heavily controlled and stigmatized. Do you have ideas on that?
Yeah, I think this is something that I was part of a conference right before the pandemic broke. Actually, we met up at it was a Radcliffe Institute for Advanced Study conference where we were looking at this very question and trying to do a deep dive with researchers who are using psilocybin and some other psychedelic assisted therapies, psychiatrists, people like Bill Breitbart and other palliative care and other folks from around the country, and neuroimaging guy like Robin Carhart, and so looking at how do we understand this and what do we think about it from a public interface. So, for example, even the word psychedelic is very charged. Or LSD, trying to do research on LSD, it's already charged, socially, and has a kind of stigma to it. But somehow these researchers are saying, when they would put in a grant for psilocybin, often most people can't even spell the word. And that was actually a good thing, because it's less stigma associated with something like that than something more classic like LSD or mescaline, which may have a more of a challenging history to overcome. So I think some of it is getting past some of the culture wars and some of the cultural stigma associated with so-called psychedelics. And actually, I think one way of actually being more honest about these medicines is actually to do a real hard look at his history and the ethnobotany that's associated with it, because I think, you know, we're trying to understand a couple of things. One is, you know, these medicines, some of them have been around for thousands of years. Indigenous tribes and others have used them. And so where is their place at the table? Why are they not talking about the potential both healing role that this has, and maybe mitigating and using these and other therapies, so it's not just something that becomes profitable for some individuals and not others. Another big critique of these studies is that they're largely done in white, upper middle class socio-demographics. And so is there the same kind of benefit across the board? You know, would psilocybin assisted therapy help my 82-year-old Dominican patient as it would a 45-year-old banker in Wall Street? I don't know. We don't have enough of that understanding. But I think really trying to tap into both, you know, thinking about where they came from and how do we bring that voice to the table and maybe learn something more about healing. So maybe healing is not this one-on-one thing, but might even be more of a community shared responsibility that happens. And many of these practices are done in a more of a community setting. So I think there's a lot that we have to really learn about and tap into, and may allow us to change some of our ways of thinking about healing, about community, about taking care of each other, and what that means, and getting it out of it being this kind of stigmatized thing, like you're going to have an acid trip on a couch and it's going to be great, but actually really moving the conversation to I think a deeper level about what is healing and how do we do that together.
And there's one more question about the participants in the NYU studies, or maybe across the board in the sort of medical research studies. Are all of the participants naive to psychedelic substances, or do some of them come to the studies with prior experiences, and then does that shape things? Yeah.
So they didn't have that as an exclusion criteria, as far as I know, in both of those studies. So I think there were a few people who had experience with in the past. I'd have to double check and see if that was the case, because since then other studies have been done, and that they don't necessarily worry so much about that. The other thing, interestingly, the same researchers at NYU have also looked at, and I don't think it's published yet, but they have been looking at using this in spiritual and religious leaders. So people who already have a deep faith tradition and then have this experience, and how does that tie in, and what's their mystical experience like, and how much of that is influenced by their religious background. So I think there's a lot of interesting work that they're trying to accomplish. But I'd have to get back to the specifics of that. I don't recall that being an exclusion criteria.
Yeah, I gave a talk at the Harvard Hillel a couple of weeks ago, and there was a rabbi on who was a part of one of these studies as a religious leader participating in this psilocybin study. It was fascinating to talk with him. So there's some questions about palliative care. Maybe we'll switch gears slightly.
Sure.
Importantly, the negative stigma of being referred to palliative care. How do you deal with that when it's seen, especially as giving up on the patient, both for family and for some physicians see it that way?
Yeah, it's a very, very common and issue that we encounter. What we train our fellows to do is to come up with their own shtick, their own kind of a way of presenting it to patients, and then modifying it depending on who they're speaking with. But basically to have some way of reframing what palliative care is, and even having a conversation about the very fact that it is stigmatized and trying to understand that. I typically just, ask people what they know about it and then clarify those misconceptions, that that's not the case and that this is what we actually do. We're here to provide an extra layer of support to you, to your family as you're going through a serious illness. We're going to be focusing mostly on your quality of life and using medications and other interventions to help reduce pain and other distressing symptoms so that you can have the best quality of life independent of whatever treatments you're doing and how much you're interested in pursuing those treatments. It's independent of that. And so I try to just take that stigma off the table as much as possible.
Would you alter that at all if you're talking about hospice? Because there it is death.
Yeah,
right?
That's right. Yeah. So if we're talking about hospice, so that would be, in the way we frame and the way we understand hospice is, unfortunately, it does require for some people to think about it as a tragic choice. That is, they're going to have to give up the potential for further disease-directed therapy to enroll in hospice. That's not the case for children, but it is the case under the law right now for the Medicare regulations at this point. Hopefully there will be some change in that, and I think we've seen some novel demonstration projects that have come out where they've integrated hospice and other type of end-of-life care models with patients who are getting disease-directed therapies, whether it be oncologic or heart failure, and seeing actually remarkable results in terms of, decreased costs, improving quality, decreasing length of stay in a hospital, and so forth. And so insurers are actually excited about that. It gets back to what I was talking about earlier, the utilitarian value of it. If you're also considering, we have scarce resources, not everyone is should be getting these treatments, certainly if it's not consistent with their values and goals, and how do we navigate that? So certainly there's a role for palliative care, but it may change. In other words, we may see some legislation changing coming down the pike where hospice could be a benefit while patients are still pursuing other therapies. So we'll see about that. But right now it is a different conversation because it does require talking about there being a very short time, usually less than 6 months. And that is often a shocking piece of information for a lot of individuals. So it can be a different conversation once hospice is brought up.
Do we have time for one more question, maybe?
Sure,
for you?
I'm open to it. Sure, yeah.
So switching gears maybe towards the advocacy role, how do you think the responsibility of healthcare practitioners as advocates intersects or not with the power of social systems in shaping end of life? And specifically, in what ways do we feel we should be focused on changing the systems that produce disproportionate suffering?
Yeah. No, that's fantastic. I love that. I love thinking about changing systems and getting past the status quo that exists. It's really requires a different kind of imagination. Can we reimagine how we think about the end of our lives? Why does it have to be hospital versus home? Why does it have to be medical versus non-medical? Where do these dichotomies come from? Can we think about new kinds of care architecture, new kinds of aesthetics that are brought into these environments, new ways of taking care of each other as a community? I thought this is clearly something that patients and families struggle with. Who's providing the day-to-day care at the very end of life? Often family members or underpaid or barely paid individuals, women of color mostly. Is this the best that we can do in terms of how we care for each other? Could we imagine some other way in which not necessarily from the system, but even from community levels? And I think the impact that interest in things like psilocybin, in other things that are coming down the pike, I think is shaking up the system a little bit to say this is not how we want to die. Right? This is not acceptable. We want it to be spiritual. We want it to have meaning. We want there to be imbibed with our values, our goals. We want it to have a sense that's beyond just the status quo. It's either I go home with hospice or I die in the hospital. So I think the advocacy will flow from our own needs as human beings. And as we start to recreate our society, I think in light of the pandemic too, I think the pandemic has given rise to a lot of understanding of what does it mean to be connected? How do we care for each other? How do we show up for each other? How can we be more mindful of everyone's suffering and think about that in a more collective space rather than an individual space? So I think there's a lot of really important work that can be done. And so I'm totally open to blowing the lids off of, system-based thinking that keeps us confined to, hospital versus home, or, nursing aid versus, taking a lethal overdose. There's all these ways in which we dichotomize our end-of-life care. And it doesn't have to be that way.
I love that. That's a great way to end, blowing the lids off of the way we've been thinking and thinking outside of the box. That's fantastic. Thank you so much, Dr. Blinderman.
My pleasure.
Wonderful. We appreciate your time and your wisdom. We wish everyone a good night.
Have a good night, everybody. Thanks so much. Bye-bye.